Hi friends, welcome to final part of diabetes, hypoglycemic episode. If blood sugar falls below 70, we call as hypoglycemia. What are symptoms? Sweating, irritability, pallor, hunger, lack of coordination and sleepiness. There is 24-hour risk of hypoglycemia. It means if patient taken tablet yesterday, the risk of hypoglycemia will be today. If he takes today, the risk of hypoglycemia on tomorrow. We can give oral or IV glucose. 15-15 rule is if blood sugar falls below 70, eat 15 grams of sugar and test after 15 minutes. If patient reaches hospital and if he is hypoglycemia, then we can give dextrose 50% 100 ml and repeat SOS in case of adults and 25% 100 ml in case of children. If hypoglycemia is not even recurring, then we can give glucagon injection, subcutaneous or IM. Remember, if blood sugar falls below 35, patient may die at any time. Maintenance fluid is by dextrose normal saline or oral glucose every half an hour. Diabetic ketoacidosis. What is the cause? Either stoppage of the insulin or expired or non-functional insulin, or acute stress conditions like acute URTI, LRTI, and acute CVA or MI and dehydration. Symptoms of diabetic ketosis: frequent urination, extreme thirst and abdominal pain, fatigue, nausea and vomiting. And if we see in blood, there is raised blood sugar level, and in urine there is high levels of ketones in the urine. And it may further lead to metabolic acidosis, in which ABG shows soda bicarb low levels, and we should give soda bicarb only if patient has severe metabolic acidosis. What is the main goal in DKA? First, maintain hydration. Fluids 15 to 20 ml per kg per hour, so that 1 liter will go in half an hour and next 1 liter in 1 hour, followed by NS or 0.45 NS 4 to 5 ml per kg per hour. That means NS 100 to 150 ml per hour. We have to be cautious while giving fluids in case of CKD and heart failure conditions. Ensure potassium level always above 3.3 milliequivalents. If patient has hypoglycemia, don't give him insulin. It will further cause hypoglycemia. IV insulin dosage 0.1 unit per kg followed by 0.1 unit per kg per hour. So if patient has 50 kilos weight, 5 units starts IV and 5 units per hour we should give. And potassium replacement not needed if potassium levels is more than 5.5, and we should always repeat ABG, ketones and RBS levels. Shift to subcutaneous insulin, basal plus bolus if acidosis recovers. What are metabolic targets in DKA? Blood ketones falling by at least 0.5 millimole per liter per hour, bicarbonate rising by at least 3 millimole per liter per hour, blood glucose falling by at least 3 millimole per liter per hour, and serum potassium maintained between 4 to 5 millimole per liter. And counsel the patient to avoid recurrences. When patient should get admission in HDU? Ketones more than 6 millimole per liter, bicarbonate less than 5 millimole per liter, pH less than 7 and GCS less than 12 and systolic BP less than 90. Next, diabetic nephropathy, complication of diabetes. So diabetes affects kidney and blood vessels will get damaged and protein will be leaking. So we can see proteinuria in case of diabetic nephropathy. If creatinine is high, patient should be given insulin only. If low, we can give drugs and control BP, sugar and cholesterol and avoid nephrotoxic drugs. Diabetic neuropathy. Initially asymptomatic to neuralgia, diagnosed with nerve conduction study and sensory testing. Symptoms: numbness and loss of sensation, burning and tingling of feet, and shooting pain and painful cramps, and hot and cold sensitivity, and food deformities, and impaired balance. Control BP, sugar, and cholesterol. What is the treatment? Vitamin B12, alpha lipoic acid, folic acid, D3, pregabalin, gabapentin, and nortriptyline. Duloxetine, NSAIDs, and control blood sugar with insulin, and add vitamin B12, folic acid, and alpha lipoic acid to improve the circulation. Control BP and cholesterol. In case of neuropathic pain, the treatment algorithm is like this. If it is focal neuropathy, if it is entrapment, then the splinting lidocaine patch. If it is diffuse neuropathy, if there is a sleep disturbance, gabapentin or pregabalin can be given. If there is diffuse distal asymmetric distal symmetric polyneuropathy, anxiety is there, anxiolytic like clonidine, followed by painkillers like tramadol and topiramate, and topicals and botox can be given. Management of diabetic foot in IPDs. Case scenario: suppose a 40-year male with FBS 233, ppbs 349, and random 298, with HbA1c 8.4, with dyslipidemia with diabetic foot came to us for treatment. Then we should advise diabetic diet and insulin in pre-op and post-op up to 3 months in some cases, and metformin in low dose we can give in post-op because it improves circulation. Can add DPP4 inhibitors and alpha glucosidase inhibitors also, but we should avoid SGLT2 inhibitors because the risk of amputation is more. And in case of intestinal obstruction, alpha glucosidase inhibitors are avoided. Insulin basal bolus or basal plus oral if sugars are controlled. So in case of diabetic foot infection, infection control is by empirical antibiotic and drainage of invasive infection, limited debridement if necrosis is present, and vascular supply adequacy assessment, revascularization should be there, and formal debridement, and culture sensitivity of deep tissue sampling should be given, and antibiotic will start after culture sensitivity. Appropriate antibiotics are given, and if it is healing well, and we can close it by secondary intention or graft or reconstruction. Management in IPD pseudo DM. Suppose a patient come with HbA1c 6.3, AC 291, and PC 312, recently received high dose of steroids for narrow root compression and dyslipidemia is there. So we should initiate or increase the dose of insulin, basal plus bolus, taper gradually with monitoring, and if steroids stop, insulin can be stopped. What causes glucocorticoids to cause diabetes like condition? Increase the insulin resistance and glycemia, increase the fat breakdown, and in the liver it causes increased gluconeogenesis, and in the gut it causes impaired incretin effect, and in pancreas it increases the glucagonic action and decreases the insulin. In the muscle, protein degradation will be there. Management in OPDs. Suppose a 45-year obese male with sugars 300 FBS, with sugar RBS 300 FBS 220 ppbs 346 HbA1c 8.2 and positive family history. Other routines are normal. We should advise diet and lifestyle and metformin 500 to 2000 milligrams. In this case, we must add another drug because metformin is not sufficient, because sugar levels are ppbs it is going up to 346. We must add sulfonylureas like more potent drugs like gliclazide and glimepiride, but gliclazide is safer than glimepiride. Along with, we can add alpha glucosidase inhibitors, SGLT2 inhibitors, DPP4 inhibitors. Management in OPD case 2, 35-year male with 60 kilo weight with AC 345 and PC 404 and A1C 9.2. We should, apart from lifestyle and diet changes, low dose metformin, sulfonylureas, because PC is going up to 404, 1 milligram BD, we can increase 2 milligram BD, and alpha glucosidase inhibitors and DPP4 inhibitors. Remember, Glimi 1 mg equal to 30 milligram of glycoside. SGLT2 inhibitors causes severe weight loss. We should be used cautious. Benefits: decrease the HbA1 level and weight loss will be there, and increase the HDL cholesterol and decrease the LDL cholesterol. Fecal excretion increased of LDL cholesterol and decrease the albuminuria and hypertension. What are the risks with SGLT2 inhibitors? Increased genitourinary infections, diabetic ketoacidosis, acute kidney injury, risk for amputation, hypotension, and bone fractures. And next is diabetes with nephropathy. A 52-year-old male with weight 76, diabetes for 6 years, RBS 261 and FBS 202, PPBS 270, HbA1c 7.7, but creatinine is 3.5 with dyslipidemia. We should advise, apart from diet and lifestyle, diabetic and renal diet. Metformin is absolutely contraindicated because creatinine is 3.5, and we can give linagliptin, DPP4 inhibitor, or SGLT2 inhibitors, alpha glucosidase, and glinides, repagliner, and etigliner, or increase the insulin. Atorvastatin is preferred in case of CKD. Next is rosuvastatin is preferred. So hyperglycemia will cause oxidative stress, inflammation, and hypertension, and inflammation will cause diabetic nephropathy, albuminuria, and end-stage renal failure. Management of type 2 diabetic kidney disease: start ACE inhibitors or ARBs, monitor blood pressure, creatinine, and EGFR, and assess and treat cardiovascular risk, aspirin or other antiplatelet therapy to treat and treat the dyslipidemia, counsel on smoking cessation, and glycemic control, or nutritional therapy and exercise and weight reduction. If blood sugar or UAE rate is not at goal, titrate ACE inhibitor ARBs to maximum tolerated dose and consider additional therapy like loop diuretics or thiazide diuretics and selective MRAs and spironolactone, eplerenone, or non-dihydrocalcium channel blockers, diltiazem or verapamil. Treatment goals in CKD: stable creatinine, normoalbuminuria, BP less than 140 by 90, and HbA1c less than 7, and body mass index less than 25 kg per meter square. So if EGFR is more than 45, metformin, EGF 30 to 45 or less than 30, meglitinates or thiazolidines and DPP4 inhibitors or sulfonylureas we can be given. So diabetes with heart failure, suppose a 58-year with weight 82 kilos and diabetes for 6 years and RBS 291 and FBS 242, PPBS 322, A1C 8.2 and ejection fraction is 30%. With dyslipidemia came to us, we should advise, apart from diet and lifestyle changes, tolerable physical activity, initiate or increase insulin with or with SGLT2 inhibitors or DPP4 inhibitors and sulfonylureas, glycoside safe, and alpha glycosidase inhibitors. With heart failure, metformin is contraindicated because it leads to acidosis, and rosuvastatin is preferred in case of heart failure. Heart failure and diabetes due to RAS activation, fibrosis, and dilated diabetic cardiomyopathy, and inflammation and dyslipidemia and endothelial dysfunction will lead to ischemic cardiomyopathy and coronary artery disease. Heart failure with established type 2 diabetes, HbA1c more than 7 despite therapy with metformin, we can give treatment goals like SGLT2 inhibitors and potential reduction in CV mortality and HHF. High risk ASCVD, GLP-1 receptor agonist, and caution in recent heart failure, potential reduction in CV mortality and ASCVD, and DPP4 inhibitors, neutral benefit on CV and HHF, and thiazolidines, increased risk of heart failure, so must be avoided. Diabetes with hyperthyroidism. In case of 59, a case of 59-year female with 49 kilos, diabetes for 9 years, AC 155, PC 232, A1C 7.3, and RBS 203. Recent TSH is normal. What we should advise, apart from diet and lifestyle changes, protein diet, and initiate and increase insulin, or with DPP4 inhibitor, alpha glucosidase inhibitor, sulfonide, or Aclinides plus reduce the metformin dose. Hyperthyroidism increased liver gluconeogenesis and peripheral insulin resistance associated with glucose intolerance. Hypothyroidism decrease in peripheral insulin sensitivity also increased with increased glucose intolerance. In euthyroid individual, there is no effect on glycemia, but with diabetes, decreased TSH response to TRH and decreased serum T3 or increase and DM in hyperthyroidism, poor glycemic control. Hypothyroidism in DM, predisposition to recurrent hypoglycemia. In autoimmune and type 1 diabetes, increased prevalence of disease. DM with hypothyroidism. Suppose a 55-year with 86 kilo weight and DM for 9 years and recent TSH is high and AC270, PC313, RBS293 and A1C 8.8. What we should advise? Weight reduction and diet and lifestyle changes and physical activity and SGLT2 inhibitors, DPP4 inhibitors, sulfonylureas, alpha glucosidase inhibitors and increase the metformin dose and increase the dose of levothyroxine. Diabetes with gestation. Suppose a 30-year female with weight 76 kilos and NC 8 months and RBS 253, AC 210 and PC 281 and A1C 8.5. Apart from diet and lifestyle, diet counseling, add in insulin or increase the insulin. So suppose gestational diabetes, if it is there, food plan and exercise, fasting glucose is more than 95, 2 hour post plan, 2 hour post plan more than 120. If fasting is 95 to 140, 114, glyburide or metformin can be given. If it is 115 to 125, combination therapy, glyburide or metformin. And if it is more than 126, we can give insulin. It will lead to diabetes can lead to fetal increased level of fetal insulin and macrosomia and child and adult obesity and cardiovascular risk disease. So this is the end of final part of diabetes. Thank you.